Lorena,
Yeah. Okay. Good afternoon, everybody. Thanks for joining us today in our transplant grand rounds. Welcome, Dr. Sheffield, and thank you for joining us today. My name is Lorena Telles. I work at the Cardio-Infantil Foundation, and it's my pleasure to introduce to you our moderators for this event. Dr. Juan Pablo Umaña, Director of Cardiovascular Surgery, and Dr. Carlos Obando, Cardiovascular Surgeon. Welcome, and thank you for moderating this event.
Buenas tardes, muchas gracias a todos por su asistencia. Mi nombre es Carlos Obando y estaré junto al doctor Juan Pablo Umaña compartiendo la moderación de esta actividad. Les recomendamos que al conectarse a esta conferencia autoricen el tratamiento de sus datos personales, los cuales serán tratados de acuerdo a la Ley 1581 de 2012 y nuestra política de datos personales, la cual la pueden consultar en www.cardioinfantil.org. De igual manera, les informamos que esta conferencia está siendo grabada. El chat de preguntas se encuentra habilitado en la barra de participantes. Les agradecemos dejar allí sus inquietudes, las cuales resolveremos al final de la sesión. Un agradecimiento especial a Astelas por vincularse como patrocinador exclusivo de esta actividad.
Gracias, doctor Obando. Y buenas tardes y bienvenidos a este nuevo horario de nuestro Grand Rounds en la cardio. Y tenemos hoy el honor de contar con el doctor Cedric Sheffield como expositor en torno a la conferencia de el estado del arte en estrategias de protección en trasplante cardíaco. El doctor Sheffield se desempeña actualmente como director quirúrgico del programa de trasplante cardíaco en Cleveland Clinic en la Florida, pero se graduó de Florida State University como químico para después continuar con su educación médica en Duke. Una vez hecho un internado en Baylor University, el doctor Sheffield realizó su residencia de cirugía en la Universidad de Maryland y posterior a eso hizo un fellowship de cirugía cardíaca congénita en la Universidad de Arkansas para terminar su entrenamiento en Cleveland Clinic, Ohio, en donde hizo un fellowship adicional en trasplante torácico. Recibió el Bryan Award for Clinical Excellence en 1999 en esa condición. Es certificado por el American Board of Thoracic Surgery y un miembro actual del Chairman's Gold Award Lifelink Foundation. So Dr. Cedric Sheffield, it's a pleasure to have you with us. Welcome, and we hope everybody enjoys the talk and we have a lively discussion at the end of it. Welcome, Dr. Sheffield.
Well, thank you very much, Dr. Umaña. Well, this is a big topic, and I've got a lot of slides, so we'll go through it and we'll move along quite rapidly here. Okay, so we're going to talk about donor organ protection strategies in cardiac transplantation. I have no disclosures, or conflicts. So at the end of this presentation, the participant will be able to understand the urgent need and benefit of expanding cardiac transplantation. I would say that throughout the world, we're not doing enough cardiac transplant. We need to do more. We need more programs. We can appreciate the limitations of donor organ availability, preventing transplant access for the patient, clarify the detrimental effects of brain death on the donor heart and the consequences for the recipient, understand available strategies to resuscitate the cardiac allograft before procurement, and develop familiarity with general allograft protection strategies doing transport and implantation, and develop a plan for managing primary allograft dysfunction. Now, clearly, we're all in the business of trying to prevent the progression of the normal heart function to heart failure. Unfortunately, we all are everywhere see the patients too late. They're referred to us when heart failure is established and the heart muscle is weak. That's the bane of our existence, that we don't get to the patient early enough. Now, one of the questions I'm often asked is, well, heart transplant is very expensive. Why are you allowed to do heart transplant? Why is the government encouraging the development of new heart transplant programs like the one we have here at Cleveland Clinic, Florida? Well, one of the reasons is because we're in an epidemic of heart failure. Congestive heart failure is the highest volume diagnosis in all the hospitals in the country, more than pneumonia, strokes, chest pain, and angina, and psychoses. It's really a huge problem. And if we look at the cost of heart failure, hospitalization costs related to heart failure, it's tremendous. It's by far the biggest cost in this country in terms of healthcare related to hospitalization. The cost of heart failure admissions is twice that of the cost of myocardial infarctions, 3 times the cost of all cancer treatments in the country. A tremendous financial burden. And unfortunately, the prevalence of heart failure increases with age. We see that very clearly. It increases first with men in the 45 to 64 age range, and then by 65, women catch up, and it continues to increase as the population ages. And in this country, and in most countries in this hemisphere, the populations are getting older. The percentage of the population is over age 65 continues to increase, and that increase in aging will not change in the foreseeable future. And so consequently, as the population ages, the incidence of heart failure increases. The numbers I showed you before with the heart failure costs were in 1990, and the incidence of heart failure, the number of patients diagnosed with heart failure, is going to increase about 3 times compared to 1990, and the costs have increased at the same rate. Now, if we treat these patients medically for their entire lifetime and don't do transplantation or other heart replacement therapies, then the cost is still tremendous. $110,000 in direct costs for treating heart failure over the lifetime if the patient is treated medically. The problem with this expenditure is that as the patient develops advanced heart failure, the money spent is largely ineffective. If we look at total cost in this country, the cost for treating heart failure, over $30 billion in 2012. It's now approaching $50 billion, and by 2030, we expect it to be close to $70 billion. So this is a tremendous financial burden. The government recognizes that, the private insurance payers recognize that, and they're looking for a solution that is effective in treating these patients. Now, if we look at what happens to end-stage heart failure patients here in the red, that are treated with optimal medical management, where we don't have the option of transplant, we don't have the option of LVADs, we don't have heart replacement therapies, we see that these patients in stage 4 heart failure have one of the highest one-year mortalities of any condition in all of medicine. It approaches that of pancreatic cancer at 80%, higher than lung cancer, higher than leukemia, higher than AIDS. So this is a tremendous problem in terms of incidence, in terms of the financial costs, and in terms of mortality. So we typically will get calls about these patients when they're in stage D refractory heart failure. And there we really only have 3 options. One is inotropes, the other is hospice, and the third is heart replacement therapy. We don't typically have the option of seeing the patient early on when we can do something to prevent their progression, because the patients aren't typically referred to us. So clearly, the easy strategy is to try to intervene earlier, take care of the patients so they don't progress. But the reality is we often see them, and we're seeing a lot of patients when they become end stage. Now, in our area of Florida, I'm originally from Florida, and I practiced in Florida for over 20 years. And I ran the heart transplant program in Tampa for 14 years before I came back to Cleveland Clinic. And one of the things that encouraged me to come back is the fact that if we look at the Miami area, this is the 20 largest cities in the country. And if we look at the Miami area, it is the area that has the least amount of heart replacement therapy, the least number of VAD implants, the least number of heart transplants, and that was a problem. If we look on the map here, to draw a circle here, there's about 8.5 million people inside this circle. So remember this number, 8.5 million inside this circle is the population. But if we look at heart transplantation in that same area, over time, we see that by 2014, only 8 heart transplants done in the entire area that encompasses 8.5 million people. So tremendous underutilization, and this reflects the experience in many countries where heart transplantation is underutilized for a lot of reasons, some of them technical, some of them financial, but the point is medical therapy of these patients is very, very expensive, much more expensive than heart transplantation, and it's ineffective. Now, at Cleveland Clinic, in 2014, we started this program, did our first transplant in October of that year, and it takes about 10 transplants and a year's time to get certified so that you can have free referral patients. And from that time, we did our first 10, then basically our numbers doubled very quickly. And 2019, we were up to 27 transplants. And in 2020, we almost had growth of 100% to 47 transplants. So far this year, in 2021, this number is up to about 22 heart transplants. So our growth is tremendous because the need is tremendous. So starting from scratch, we've grown this program and we've had tremendous success. Now, not only does heart transplant address the mortality risk, but if we look at functional status of patients after heart transplant, about 95% of patients, remember these are stage D or New York Heart Association class 3 or 4 patients who are very debilitated after heart transplantation. About 95% of them have no limitations, and that's sustainable at 1 year, 3 years, and 5 years. So heart transplantation has tremendous mortality benefit, tremendous quality of life, functional benefits as well. Now, if we look at survival after heart transplant by era, we see the heart transplant survival is very, very good over time. And this is sustained. I have hundreds of patients who are out more than 20 years after heart transplant. And remember that survival without heart transplant is 80% mortality in 1 year. So this is a tremendous survival benefit. So beginning in the cyclosporin era, in about 1980, we started using cyclosporin for kidneys. By 82, we started to use it in heart transplants throughout the world. And we had a tremendous increase in transplants everywhere. And so that increase went up, and unfortunately, the increase in transplants peaked about 1993, and then it settled back down. Well, why did it peak? Well, one of the reasons it peaked is because of limited donor organ availability, either in terms of having permission to utilize a brain dead person as a donor, or having donor quality issues. So donor organ limitations continues, and it's a big problem even today. So if we can do things to improve availability of good quality donors, it can make a big difference in terms of access to transplant. So if we look at heart transplant today, we have about 400,000 new diagnoses every year. We have about 370,000 patients in class 3 and class 4 heart failure. And yet the number of transplants ranges between 2,000 in this country to 3,500 per year. So even though we do the best we can with transplant, we still are treating the tip of the iceberg. So the point is, there's tremendous need, there's tremendous opportunity. So everything we can do to increase donor quality, donor availability, the need is immediate and a desperate need. Now, one of the things we've done to manage donors in this country is recognize that if we look by age, from age 18 to age 69, people that get transplant do about the same, okay? There's a small advantage of being younger, but it's not a statistically significant advantage. However, when we look at those over age 70, they do about the same as everyone else for 5 years, and then mortality increases markedly due to age-related issues. So one of the things that most programs will do is they will limit transplantation to those under age 70. And they do this to try to preserve donors for those who are younger. So that's one strategy. It doesn't really work though. And one of the problems with that is there are also donors who are older who are not going to be used for younger people that may be more appropriate for patients that are over 70. So that's another issue. But trying to save donors for the youngest patients doesn't really work because the numbers are overwhelming. So clearly, like I said before, if we could get to these patients earlier and do more conventional therapy before they get to stage D refractory heart failure, that is ultimately going to be the answer. But that's not our reality today. So let's talk about donors and what makes a young person into a donor. Most of the time, donation eligibility is defined by brain death. So brain death, whether it's traumatic, like here with a patient with an automobile accident and a massive subdural hematoma, essentially brain dead at the scene of the injury, or a patient that has cerebral edema and then has uncal herniation due to this edema. The consequences of brain death on the heart and all the other donor organs is not trivial. Now, during the time development of heart transplantation technology, we were doing animal experiments where we would have an anesthetized donor animal take the heart out, protect it for a period of time, put it into the recipient animal after cardiectomy, and we found tremendous return of function. And so in donor animals, it seemed that we had figured out how to do the operation. We'd figured out how to protect the donor organ for appropriate amounts of time, and it worked very well. Well, once we developed cyclosporin, we started doing heart transplants, and those university programs doing this research discovered a phenomenon where taking the heart out of a donor and putting it into another human, we had a relatively high incidence of the donor heart not working very well. It did not reflect what happened in animals very well. And we spent a long time trying to understand why we could not utilize donor human hearts after brain death in the same way that we use the animal hearts in the experimental laboratory. And so this was a limitation on the growth of organ transplantation for quite a long time, trying to understand this phenomenon. Now, the brain death effects that we see, the immediate effects we found were greater in young donors. It wasn't clear why this was the case. But one of the things that was figured out by David Cooper and Dmitry Nowitzki in Christian Bernard's laboratory at Cape Town, South Africa, is that at the time of brain death and herniation, there's sympathetic overload. And the young people have a very active, competent sympathetic system that can drive the heart very hard, resulting in hypertension. And by hypertension, I mean profound hypertension, sometimes systolic blood pressures of 300 at the moment of herniation, tachycardia with sinus tachycardia rates of 200, again at herniation. Now this leads to a very short diastolic phase of the cardiac cycle, which is when the heart receives the majority of its blood flow. And this results in subendocardial ischemia, decreased coronary blood flow, and subsequent mitral valve papillary muscle dysfunction, mitral regurgitation, pulmonary hypertension, RV overload, distension, and ultimately tricuspid regurgitation and venous hypertension as a result. So this is one of the immediate effects of brain death. So during this time and figuring this out, intermediate steps were developed. And one of the important steps was the understanding that there needs to be some time separation between the time of brain death and the time of procurement with good hemodynamics during that time to allow the heart to recover. So we started to make progress and actually grew these numbers. Now, the delayed effects of brain death, hemodynamic instability. Now we go from tremendous sympathetic overload to no sympathetic nervous system at all, with peripheral vasodilatation, hypotension, hypovolemia as a result of that, arrhythmias, including atrial fibrillation, decreased coronary blood flow continues, decreased contractility, decreased ability to tolerate ischemia. And this is one of the major differences between the brain dead human and the experimental dog animal in the laboratory, was that the dogs had not gone through brain death. And then finally, very importantly, apoptosis, where there's programmed cell death as a result of the effects of brain death. These are things that were figured out in Dr. Christian Bernard's laboratory. So the treatment. Number one strategy is delay in procurement. Try to separate by at least 24 hours brain death and the procurement. It increases the ability of that heart to tolerate ischemia. Dedicated donor-specific critical care. Now we have two teams. There's a team of critical care doctors taking care of the patient before brain death, and they're doing steps to try to prevent progression of brain death. Once brain death has occurred, then a separate team now is donor-specific critical care trained, and they take care of the donor organs. We do hemodynamic resuscitation, and finally, we await organ functional recovery. There's a protocol based upon the work done in Cape Town. It's called the Crystal City Protocol. It's fairly universal in this country now. First proposed in 2004, adopted in 2005. Now, based upon our work with routine cardiac surgery, where we stop the heart and protect the heart, we developed a number of protection solutions. And these solutions have two goals. One goal is to stop the heart. And to do that, they have various amounts of high potassium. So they have, in general, an intracellular levels of potassium. So they eliminate the electrochemical gradient across the cell membrane, and so that there's no oxygen potential generated. Now, the amounts of sodium and other electrolytes varies widely. The solution that we use typically is UW1, University of Wisconsin solution. It's the same kidney used as the same solution used to protect the kidneys and protect the liver. So it's fairly universal. It's one of the most widely utilized solutions, and it fits our needs very well as being economical and widely available. Now, as part of our protection strategy for this donor heart, we recognize that the very long period of ischemia, of cold ischemia, has consequences. Now, when we do cardiac surgery, we will stop the heart. We will intermittently give cardioplegia protective and nutritive solutions about every 15 to 20 minutes. And we may do that for 60 minutes, or in a long operation, 120 minutes. But for the donor heart, it may be up to 4 hours with a single injection of solution, and then undergo global cold ischemia for a prolonged period of time. One of the consequences of that is that Krebs cycle intermediates can be depleted. They can leach out of the cell and be lost. And these are the mechanisms by which energy recovery happens, in ATP generation happens after the transplant. So we spend some time at the end of the transplant repleting Krebs cycle intermediates using a solution called Buxberg's Cardioplegia, a blood-based solution that has aspartate and glutamate, which then leach into the cell and reconstitute the Krebs cycle. Now, the other concept that we pay attention to is the idea of preserving nucleotides, that is, preserving adenosine that has phosphate attached. So we think about ATP as the powerhouse of the cell, and it is metabolized to ADP, generating energy. And ATP and ADP are both trapped in the cell because of the presence of the phosphate moiety on that molecule. It can then be enzymatically or non-enzymatically metabolized to AMP, which again stays in the cell because the phosphate is a large molecule won't allow this molecule with its highly negative charge phosphate tail to leave the cell. However, if over time this last phosphate is cleaved and AMP goes to adenosine, adenosine does not have phosphate, it washes out of the cell. And if that happens, then we can deplete the precursors for making ATP. So part of our goal is to try to prevent the loss of this last phosphate so that we can rapidly generate ATP using Krebs cycle aerobic metabolism at the end of the operation. Now, based upon this Crystal City protocol, we have a relatively detailed donor procurement algorithm that begins with conventional management. Again, this is done by donor critical care specialist. Hang on one second, we'll go backwards. Where we adjust volume, we correct acidosis, we correct electrolyte abnormalities, we correct anemia, we add inotropes to keep mean arterial pressure at high enough level to perfuse all the other organs. Oftentimes in small hospitals that are doing donor care, they will use dopamine, and in our hospital, we'll use other inotropes and pressures. We obtain initial echo, and if the ejection fraction is greater than 45, we proceed with procurement for the organ. If it's less than 45, then we will undergo hormonal resuscitation using a combination of things discovered by this group in South Africa. And that includes steroids, insulin, and thyroglobulin. I'm sorry, and thyroxine. So steroids, insulin, and thyroxine. And we'll add vasopressin at very low physiologic doses. And so this is a very important part of our hormonal resuscitation. It's shown that it improves cardiac function, improves the function of every donated organ, and it increases the number of organs that the donor is able to donate. Now, following resuscitation with hormones, which again takes some time, 12 to 24 hours, during that time, we optimized the hemodynamic management and using fairly usual criteria. And if we're able to do that, then the criteria are met for function, and then we proceed with recovery. If they're not met with functional recovery, then we don't procure that heart at present. And we'll talk at the end about some ways we may even be able to recover those hearts. Now, procurement strategies, we'll not go into tremendous detail here because, for instance, of time, but basically their age requirements, and typically we'll use donors now up to age 60. And we try to size match the donor and recipient. So the donor is the same size or larger than the recipient. We avoid left ventricular hypertrophy, even if systolic function is normal. We avoid valvular lesions, but if there is mild or moderate tricuspid valve regurgitation, we'll use those hearts and repair the tricuspid valve at the time. Occasionally, we repair mitral valves. ASDs or PFOs, we will take care of and use those hearts with impunity. And then we do coronary angiography in male donors above age 35, female donors above age 40 to ensure that there's no coronary artery disease. If we're in desperate need of a heart, we'll sometimes look at the much older donors, and if the function is normal, the valves are normal, and the cardiac catheterization is normal, we can then use those hearts. Now, after transplant, we'll continue the donor organ resuscitation in recipient, just as we did in the donor. And we'll use pulmonary artery catheterization in every heart transplant. We'll then do good medical therapy in terms of fluid balance, electrolyte replacement, avoidance of anemia, and we'll use pressors that we'll talk about in a little bit, as well as inotropes in every case to maintain good organ function. We continue the hormonal resuscitation that we started in the donor. We'll continue it in recipient. We don't give the same high doses of T3. We lower that to about 100 micrograms IV per day, but we'll continue vasopressin, solumedrol, and insulin in the recipient. Now, for our patients, very importantly, we, because of allocation reasons, are typically only transplanting very sick patients. Most of our patients, I would say 95% of them that we're transplanting today, we transplant in stage 4 heart failure with some temporary assist device, either intra-aortic balloon pump or Impella or ECMO. And if the patients have ECMO or intra-aortic balloon pump, after transplant, I don't immediately take away those supportive measures. I leave them typically for about 24 hours to ensure that the donor heart is working well before I take away the balloon pump or ECMO. And we'll commonly use a subclavian artery approach for balloon pump, and that allows the patient in the ICU before transplant to walk and participate in physical therapy, and we'll continue that subclavian balloon pump and continue physical therapy with the balloon pump in place post-transplant until we demonstrate that heart is doing well. For patients with ECMO, we don't take ECMO out immediately. I used to, I would say 10 to 15 years in the past, but we see benefits for leaving ECMO on for a short period, 12 to 24 hours after transplant. So this is where we stand today with transplant. We have a slight increase in the number of transplants, but that increase does not nearly keep up with the need. So one of the things that we have to think about in terms of our ground rules for donor management is how long this whole process can take. It's very clear that we have to minimize warm ischemic time, and we can get the warm ischemic time down to practically zero with our strategies. Total cold ischemic time, we try to keep less than 4 hours. And the basis for that is if we look at the UNOS data that shows what happens to survival in the recipient. This is not your, so this is survival years after transplant. And this is for patients with ischemic times less than 2 hours or less than 4 hours. And those are overlapping. No difference between 2 hours and 4 hours in terms of survival. However, if we go up to beyond 4 hours, then we see a big drop in survival. And if we go beyond 6 hours, a tremendous drop in survival. And that drop in survival is immediate. So this is the basis by which we try to keep donor ischemic time less than 4 hours. Now, for allograft procurement and protection, I'll go over this very quickly, probably more relevant to the surgeons than anyone else. At the time of procurement, we vent the venous system, and that's very important to avoid right ventricular distension. Most of the problems with the early graft dysfunction are right ventricular issues. We cross clamp, we give a cold preservation solution. In our case, we use University of Wisconsin, UW1. We do topical cooling with ice in the pericardium. And very importantly, other organs are being procured. The lungs are being procured, the liver being procured, and they're being perfused with various solutions. And those solutions drain into the venous system, into the region of the heart. So we try to control heat transfer from other organs so that we don't harm the heart, and we excise the heart first. We examine the heart on the back table for anatomic abnormalities, such as a patent form of novale, which we see in about 5% of the time, and we fix that at the time. We look for a coronary artery disease that was missed on the catheterization of the donor. We examine all valves. We look for persistent left superior vena cava, which we'll see about 0.5% of the time. And of course, we explore and repair the patent form of novale. We very carefully package and suspend atraumatically in preservation solution the heart. Temperature of greater than of approximately 4 degrees centigrade, not freezing. We don't want the heart to freeze. The heart never touches ice. It has no contact with solid surfaces. So in our program, we use a hard package to to package the heart. Now, if we do all of these things, we're still not in the clear because 20% of the time we're going to see primary allograft dysfunction. And so we have to have a plan on how we're going to manage that. And one of the tenets of this is that when we see primary allograft dysfunction, we rest the heart on cardiopulmonary bypass, and not for 3 minutes or 5 minutes. We rest for 20, 30, 40 minutes, up to 60 minutes to allow that heart a chance to recover, where it's being fed, but it's not doing any work. And during that time, we do the usual hematologic and hemodynamic optimization, correct electrolytes, correct the hemoglobin, and we adjust our inotropic and pressure support. Our inotropic support is always minorenone, epinephrine, vasopressin. That's our baseline for every heart transplant. And we don't wait until the heart gets in trouble, because the RV will dilate and then it won't recover for days or weeks. We continue the hormonal resuscitation we started in the donor, including steroids, insulin, and levothyroxine. We optimize our refilling, RV distension at all costs. When we have graft dysfunction, it's typically not an LV problem, it's typically an RV problem. Now, if we continue with RV dysfunction despite all these measures, then we use inhaled pulmonary vasodilators, Velitri. We use primarily because of the economics of it. If it doesn't work, we'll go on to nitric oxide, which is expensive. We use typically 20 to 40 parts per million inhaled, and nitric oxide has toxicity, and so we have to monitor carboxyhemoglobin levels. And the toxicity exhibited when the carboxyhemoglobin levels are above approximately 10%. If we continue with the allograft dysfunction, then we will liberally pack the chest open, allow the heart to recover for a few days, and then typically we get rid of edema in the donor heart and we can close the chest and get back to a normal course. We'll use intra-aortic balloon pump if necessary, even if the patient didn't have one ahead of time, and arteriovenous ECMO in extreme cases where we have recalcitrant right ventricular dysfunction or biventricular dysfunction. When we have dysfunction, we move to early biopsy. Our typical routine is to biopsy at 7 days, but we'll biopsy at 2 days or 3 days if we have severe allograft dysfunction. We make a diagnosis, we treat rejection. We get our biopsy results back typically in a few hours, and if we can diagnose cellular antibody-mediated rejection, we treat that very aggressively. And if all these measures don't work and the heart just will not work, we'll consider retransplant. Very unusual. I would say about 1 retransplant every 200 heart transplants, so it's not very common. So if we look at our routine here at this hospital in detail, we take a 2-team approach. We have 2 teams with 2 attending surgeons. One is a donor team, one is the recipient team. We limit our travel time to 3 hours. Our total allograft ischemic time we limit to 4 hours. And once the heart gets back, we're always prepared to start the implant within 5 minutes of the heart arriving back in our operating room. We have very tight communication between the donor and recipient teams. Once the donor heart is visualized, then it's communicated to the recipient team, and the recipient team starts the operation. Now, the donor team is on standby while the recipient team is doing the recipient operation. It may be a first-time sternotomy, which takes no time at all, or it may be a multiple redo with LVAD explant, and the recipient team may need a couple of hours to get that donor, to get that recipient dissected out. But the donor team waits until the recipient team is ready. Now, for the donor team, there's minimal dissection we do before cross-clamp. At the time of cross-clamp, when all the organs are ready and our recipient team is ready, we clamp the superior vena cava. We vent the inferior vena cava widely to prevent warm perfuse it from the liver to damage the heart. We decompress the heart first, then we cross-clamp, and we perfuse the heart in the chest with 2 liters of this UW1 solution. We incise the left atrium to vent the left side of the heart, and we put topical ice into the pericardium. That's the only time that the heart touches ice. We control the effluent from the heart and from all the other organs, and especially we control heat from the liver. We excise the heart before other organs. We keep all the great vessels because we have a number of redos and congenital heart disease where we have to reconstruct the great vessels. On the back table, we perfuse another liter of cold UW1. Now we don't have to worry about other organs warming up our heart. We prepare PFO on the back table if necessary. We package it in our atraumatic sling packaging at 4 degrees, not touching ice, not touching any hard surface. And then the recipient team is notified at every stage of the travel, and the donor team tracks the ischemic time. The recipient, on organ visualization and final acceptance, we start the recipient operation, we do the sternotomy, we do the redo well in advance of the organ arrival. And if the recipient is ready and we're dissected and it takes 2 hours for the donor to be ready, well, that's okay. We'll take that. We always have the recipient ready ahead of time. We give steroids to the recipient in the operating room. Many programs will give it on the floor. I find that I like to see the steroids going in myself so that I can be sure that they were given and we don't have an IV problem or someone forgot to give the steroids. So we give them in the operating room. Not ideal, but it gives us confidence that they were given. When the donor plane lands at our airport here, they're still about 30 minutes away, but we start cardiopulmonary bypass and take out the native heart. When the donor team arrives in our hospital, we immediately take out the donor heart, trim the left atrium to size, and start the implant. And typically, from the time that the donor team gets here until we're starting to put the first stitch in is between 1 minute and 5 minutes. We do the left atrial anastomosis first. We then administer cold Buchberg's cardioplegia into the donor aorta. This is one of the solutions we use on conventional cardiac surgery to protect the heart. But it has the advantage that it resuscitates Krebs cycle intermediates, and it also prevents deterioration of ATP down to adenosine. We perform the inferior vena cava anastomosis and then give a repeat dose of cardioplegia. We do a 2-layer aortic anastomosis, and during this time of the aortic anastomosis, we start to warm the patient up and warm resuscitative cardioplegia. And then we give this resuscitative cardioplegia, recharge the Krebs cycle, and take off the cross clamp. So we only do 3 anastomosis before we take off the cross clamp. So the reperfusion typically happens 30 to 40 minutes from the time that the heart arrives. So now this ends the ischemic time, and the anesthesiologist can start the inotropic and hormonal support of the new heart. We still have work to do. We perform the pulmonary artery anastomosis and perform the superior vena cava anastomosis. At this point in time, typically the heart is resuscitated. We perform de-airing maneuvers, we fill the heart, perform a baseline TEE, and if we're happy with that, then we wean off cardiopulmonary bypass. We optimize the filling pressures based upon the right ventricular Starling curve, and we'll add inhaled pulmonary vasodilators if it's necessary. And so that pretty much sums up our process. And with that process, we really rarely see primary graft dysfunction. I would say it's approximately 5% of the time as opposed to a national average of about 20% of the time. So this very simple process works exceedingly well for us. Now this is one of our patients, a pre-transplant patient that came to us after having a gastric cancer that was resected and treated with chemotherapy. And the patient was 3 years following resection and chemotherapy and developed chemotherapy-induced cardiomyopathy and class 4 congestive heart failure. The patient was very sick, but she could not get a transplant because she was only 3 years from resection of a gastric cancer. So we took her to LVAD. We put an LVAD in her, and this is her after she was managed on the LVAD. And she managed on LVAD for another 2 years until she was reevaluated and declared cancer-free. Once she was declared cancer-free and this cancer was demonstrated cured, we then did transplant, and post-transplant, had normal heart function, back to normal life, normal exercise, a very thin, very active woman, runs a mile at a time. And so this this is a patient that ordinarily would be quite difficult, but with our donor protection strategies, we're very confident taking care of this patient. And we routinely are taking care of complex patients with very good results. As a matter of fact, from a quality standpoint, even though our program only started in 2014, the SRTR and UNOS found that our program, by quality standpoints, is the fourth highest quality in the country, which is very good for a new program. Now, that's where we stand today. Where we're going in the future. In the future, we may get away from the idea of cardiac arrest and cold ischemia in preservation while we're protecting the heart. There's the concept of continuous warm blood perfusion, and this is one of the devices designed to do that. This is a Transmatics device. It has modules for perfusing heart, perfusing lungs, and perfusing the liver. And this is a different strategy where instead of making the heart ischemic and protected, we perfuse it the entire time with oxygenated blood. And this shows a heart in this device, and we can see the heart working the entire time. And we're starting to use this for DCD hearts, for hearts after where the donor is not brain dead, but is irreversibly injured from a brain standpoint, and the patient is declared dead by cardiac death, where they're at their request or their family's request, they're taken off a ventilator, the heart is allowed to stop, and then the heart is procured and then placed on this Transmatics device and allowed to recover on the device, is evaluated and then found to be an adequate donor organ. So that's something for the future. Right now for DCD or donors after cardiac death. One of the questions is for standard donors, is there a benefit of taking the heart out, not cooling it down, putting on this machine and transporting it on the machine? And will that allow us to go beyond 4 hours to 6 hours or 8 hours? Will it also allow us to take a heart that has functional issues and put it on this machine, perfuse it, and reevaluate it and look for recovery? And if that heart recovers, we use it from this machine after a period of time. So that's where we're going in the future. We're not there yet, but I'm very hopeful that this is a promising strategy and technology. Well, thank you very much for allowing me to talk to you about our experience, and everyone, please stay safe. I will say that one of the things I wanted to talk about was the fact that we have a new program started from nothing in a 155-bed hospital, and we're able to create a program that's growing very fast, 100% growth in the last year, and it's been found to be the fourth highest quality program in the entire country. So I think that points to the fact that with these established strategies, transplantation can be done. It can be done reliably, and it can be done really quite easily. And so I think that as a discipline around the world, we need to look at the possibility of trying to increase the availability of heart transplantation. We all work together to try to make it happen, because this is the solution for many of the patient's problems, with heart failure being the #1 growth rate diagnosis in the world right now. Well, that being said, thank you very much, and I'd like to see if there are any questions.
Dr. Sheffield, thank you very much. That was great. That was a great talk, great introduction, and then very interesting follow through, and very generous, as you all guys always are, with your knowledge and impressive results. I'd like to ask Dr. Ovando, see if there are any questions in the chat, or if he has a question. I know he will have plenty of questions, and then perhaps anybody on our heart failure team that's in the audience, whether they have any questions. Dr. Ovando?
Thank you, Dr. Sheffield, for an excellent presentation. I have some questions. The first is, are there differences in the severity of the cardiovascular effects of brain death according to the cause of the death?
Well, that's a very, very insightful question. Well, absolutely. And this was, that's has been examined extensively, and the folks who started this line of thinking, especially Dr. Dmitry Novitzky, has looked extensively into this using a primate model of brain death, where he found that if there is sudden brain death, sudden herniation, then that is the greatest stimulator of this sympathetic overload. Brain death happens slower by a mechanism such as blunt trauma to the head with edema and slow herniation, that the brain death is worse when it happens quickly. So in a clinical scenario where we see the greatest problems are young patients who undergo gunshot wounds to the head with sudden brain death. That's much greater problem than those donors who have brain death on the basis of, say, automobile accident. So that is one issue we're seeing. And I'll take a second to mention that we're increasingly seeing brain death on the basis of anoxia due to drug overdose. We're in the middle of a drug overdose epidemic right now, and it takes some time for the reports to come forward, but I expect that the number of drug overdose deaths in this country will wind up being in the 70 to 80,000 per year range, considering that we will do between 2,500 and 3,500 heart transplants. We're increasingly utilizing donors after drug overdose. And I don't think we see the same degree of donor issues related to sympathetic overload in those patients, but I think we see donor issues related to the direct toxicity of the drugs.
Thank you, Doctor. I have a specific question, and it's how is your myocardial protection protocol during the donor organ removal process, specifically in pediatric population? What preservation solution do you use in pediatric patients?
Okay. Well, I would say that at this hospital, we don't do, we don't have a pediatric population. We're an adult-only hospital. We don't do obstetrics, so we never see babies in this hospital. So our program is adult-only program, but I have extensive experience with pediatric transplants, and I'm trained in pediatric cardiac surgery. So I would have typically used UW, the University of Wisconsin one, in the pediatric population. I will say that in the pediatric population, during my work at Arkansas Children's Hospital, where we did a lot of heart transplants, we found a couple of things. And one is that the pediatric hearts are much more resistant to ischemic damage than adults. So the pediatric hearts, I think, in many ways are easier to protect because especially in the younger population, there's no issue with acquired disease. The issues of congestion and pulmonary hypertension are not there, and so it's easier to perfuse and take care of these hearts. But we know that in the young neonates that the heart is much more resistant to ischemia, to global ischemia, and we see this in pediatric heart surgery as well, in congenital heart surgery. So we used UW. We've had very good results with that, but we do continue to use hormonal resuscitation. There's not good evidence in the scientific literature for using hormonal resuscitation in the neonates, but we do it because of our experience in the adult population.
Okay, thank you. Here we have another question. Specifically during the surgical removal organ process, what technique of administration of the preservation solution do you use to prevent myocardial edema?
Okay, well, there's a couple things that we do. We use a typical cardioplegia needle proximal to the cross clamp to give the solution. We give the solution at a controlled pressure, a mean pressure of 80.
80. Okay.
And so we don't hang the solution at an unknown pressure. We monitor the pressure very carefully. Use isotonic solutions. That's one of the reasons why we use UW as opposed to some of the other hypotonic solutions that may contribute to edema. And very importantly, we vent the right side extensively, even sometimes completely dividing the inferior vena cava. We use suction catheters inside the right atrium, and we divide the pulmonary veins or the left atrium so that there's complete drainage of the left side of the heart. Now, occasionally during the perfusion, there will be some induced AI so that the left ventricle will dilate. And if it tries to dilate, then we will actually open the left atrium and put our finger across the mitral valve to decompress the left atrium. So with these maneuvers, today it's, I think, relatively easy to avoid the myocardial edema we used to see in the old days. And we follow up every biopsy, the first biopsy, looking for evidence for procurement-related damage and edema, and frankly, we just don't see it.
Perfect, I understand. What's your opinion on ex vivo preservation technologies like organ care system, Transmedic? Specifically, do you think this type of technology is cost effective?
Well, I think it's going to depend upon the program and the details. I would say for my program, I don't think it's cost effective for the routine patient, because we have excellent results with what we're doing, which is very simple and very economical. That's using the limitations that we set on ourselves regarding travel time. But our travel time, we typically, within 3 hours, we can go halfway across the country, or we can go as far as Puerto Rico, or even to southern Canada in 3 hours. So it gives us a very large area that we can work from. However, if we were looking at a donor in California or Arizona, we really can't do that now. That would put us greater than 4 hours ischemic time if everything is perfect. And we always leave room in case there's some delay, weather delay or mechanical delay with the plane. So we don't go over 4 hours as planned. Because of mechanical issues, because of weather, we have had ischemic times out to 6 hours, and we've done very well with that, but we don't plan on that. We try to plan to have ischemic times less than 4 hours. The Transmedic device hasn't been demonstrated yet to allow this, but if it could allow us to go hours routinely, that I think would be the benefit. If it could show that we can go out to 6 hours or 8 hours, it would allow us to travel throughout the entire country. And especially for patients that are unusual size, they're very large or very small, or patients that are highly sensitized, maybe their panel-reactive antigen is greater than 90% and they can't get a heart because they have antibodies against most of the population. They may benefit from casting a wider net and using a device like Transmedics. And I think the other potential use for Transmedics, if we see a heart where the ejection fraction is 40%, and we'll sometimes see this, especially in patients who undergo brain death due to cardiac arrest due to drug intoxication. We'll oftentimes see these patients where they've had cardiac arrest, they've been found, they're brain dead. No one knows how long this cardiac arrest has been going on, but they are successfully resuscitated so that they have return of cardiac function, but the ejection fraction may be 40%. in those patients, if we could put that heart on a mechanical device and measure function and perhaps do some interventions to try to encourage greater function. If it doesn't work, well, we then use that heart for research purposes. But if that heart will demonstrate normalization of function, then perhaps we can use more hearts from the population that has drug overdose. So I think that that's the potential future for transmedics. But for us today, I don't see a reason for us to utilize that machine for that cost.
Yeah, thank you. What kind of fringe donors do you use in your heart transplant program?
What kind of which one?
Marginal donors.
Marginal donors?
Yeah.
Well, we're very aggressive in donors. We're one of the most aggressive programs in the country at evaluating donors. So our attending surgeons discuss every single donor. We don't have any automatic denials of donors based upon anything. So every donor that we get offered, we look at very carefully, and we look at the reports, but we also look directly at every EKG, every echo, every heart catheterization. And we do that because as part of our understanding of brain death effect on donors, we expect that there will be donors that will have temporarily decreased ejection fraction. And many programs will turn those donors down, and we will not. We will stay with that donor. We'll ask for resuscitative measures, including hormonal therapy, and we'll give time, and then we will ask for repeat echo and look at that donor. So we lead the country in looking at actually utilizing donors that have been turned down by more than 50 programs. We also lead the country in utilizing hearts that come from greater than 500 miles away. So the biggest issue that we look at in terms of marginal donors is the logistics of getting to the donor and getting the heart back to us. And we're very aggressive at trying to push that.
Yeah, perfect. We have a question from the audience. Do you have a higher age limit even if you have a normal angiography?
In terms of donor recipient?
Yeah.
Okay. Well, for donors, we will look at donors up to age 60 for our routine recipients. Beyond age 60, at this point in time, we don't utilize them. That may change in the future, but right now we don't utilize donors older than age 60 for heart transplant. Now, on the recipient side, routinely we will do heart transplants up to age 70. We don't have an absolute age limit, but above age 70, we look very carefully at the recipient to try to understand what is going to be their age-related mortality outside of heart issues. And so those patients are looked at very carefully. Most of them will have some issues such as diabetic complications, or they will have vascular disease that's likely to progress, or abdominal aneurysms, or some metabolic disease that makes it so we feel that their mortality risk after heart transplant in the long term is too high. But we have transplanted patients of many age groups when that patient was in exceptional shape at an older age. We'll take a look at them. As a matter of fact, I just saw today in my clinic a patient that we transplanted 3 weeks ago who was 71 years old. But this is a patient who's exceptionally functional, except for heart issues. He exercised every day. He works every day. He has no physical limitations until his congestive heart failure limited him. And so this patient we transplanted 3 weeks ago, and he got out of the hospital after 10 days. And I saw him now, he's already walking 1 kilometer per day. So he's doing very, very well, and selected patients can do that. So we look at age, but it's not an absolute contraindication. If the patient is older, we just look at them very carefully to try to make sure there's not any hidden problems to be found.
Thank you, Dr. Sheffield. Doctor Umaña, ¿tiene alguna pregunta?
Ninguna otra. Creo que debemos dar las gracias, doctor Sheffield,
Yes.
y dejarlo descansar en viernes.
Listo.
Dr. Sheffield, thank you so much for your time. Thank you very much for being with us this evening, and we hope you have a wonderful weekend down in Florida. It was a pleasure having you, and we hope to be able to see you again in the future, and hopefully in person.
Well, thank you very much. I really appreciate your generosity and allow me to share some thoughts with you. And as you know, we always learn together, and I appreciate the camaraderie that you all have shown us. And I tell you, this is a bit of a war with heart failure, but I'm confident this war will win by working together.
I'm sure we will. And with you know, as long as we have people blazing the trail as you guys are doing, I'm sure patients will benefit in the future. Thank you very much again, and have a great evening.
Well, thank you very much.
Gracias a todos.
Thank you so much, Dr. Sheffield. Thank you.
Adios.
Bueno, gracias a todos los participantes por su asistencia. Gracias nuevamente a Astelas por su apoyo para el desarrollo de esta conferencia, y hasta una próxima oportunidad.
Gracias a todos. Hasta luego.
Hasta luego.